I think definitely it's the interactions with our physicians. I have a lot of patients who say that they really value the fact that I and other physicians sit down and really explain test results and lab results and what the options are for care, and instead of just saying, this is what you need to do, this is what you have, this is what you need to do, see you later, goodbye. So I think they really enjoyed that interaction and the ability to ask questions and kind of get a better idea of what their disease is about and why and how we're treating them. In lung cancer, unlike in some of the other fields, we've really are beginning to understand that there are many different lung cancers caused by many different molecular or genetic abnormalities. And so we're beginning to really tailor our treatment. So instead of just across the board treating everyone the same, we're able to target our treatment to what the underlying abnormality that caused the patient's lung cancer. And a lot of times by doing that, we're able to eliminate a lot of the toxicities that we get from just the chemotherapy that's just generalized. We have a lot of the similar treatments to the community, but we have some clinical trials that are going on right now as well. One of them, for which I'm actually the principal investigator, is using a specific targeted a specific drug that targets a specific pathway. And using this drug, we're hoping to reactivate the body's normal checks to prevent tumor growth. And this drug, because it's so specific for an abnormality, has very few side effects. We're finding that our patients are doing really well on this drug, not having a lot of the toxicity that's associated with traditional chemotherapy. There are other trials as well that we're either have or in the process of having that are really trying to target our treatment to specific populations that would be predicted to respond better to it and therefore have less toxicity. One of the other things that we do here a lot that I think is really unique is that we are very aggressive in our approach to lung cancer patients. A lot of times in the communities, a patient has stage 4 lung cancer and the physician will kind of just say, well, you have stage 4, we'll do chemotherapy, there's not much hope. And what we try and do is give them a realistic picture, but at the same time help them be very aggressive about treatment. So we actually use SBRT, stereotactic body radiotherapy, for treating specific sites of metastases where the tumor has spread from the lung to another place. And we use that a lot to help control the disease better, I think, and we're finding that we're actually, people are doing better in the long run by treating with definitive therapy places where the cancer has metastasized, rather than just solely relying on systemic chemotherapy. In a lot of places, you have something in the lung, something in the liver, a spot in the bone, and they're like, well, chemotherapy, that's it. But we're actually able to give radiation to the liver and to the bone and help control the disease longer than if you just gave the chemotherapy. So I think we're really seeing better outcomes that way. Most important thing is for the patient to understand what they have, to reassure them that they really didn't do anything bad. I know a lot of times lung cancer specifically has a stigma where people sometimes feel that they brought this on themselves, and I try and reassure them that this is a disease just as diabetes is, and it's something that moving forward we're going to try very hard to work together as a team to help them get through it, to help them deal with the implications of what they have, and help them and their family work through it together.